Welcome to Medical Evidence Matters with me, Liz Tucker, the podcast formerly known as What Your GP Doesn't Tell You, the show aimed at doctors and patients. This week, I'm talking to Dr. Guido Frank about his research into anorexia nervosa that, although at an early stage, has had some remarkably promising results. Anorexia is a disease which is one of the hardest psychiatric conditions of all to treat, with a depressingly high mortality rate. So this work is of huge interest. I heard Guido a while back give a presentation at the conference Metabolic Psychiatry, Understanding How Modifying Metabolism Can Create Mental Health. And I've been really keen to have him on the podcast ever since. Up to now, there's been no effective treatment for anorexia, and no medication has ever been approved for it, which is an added worry for relatives and patients already going through an incredibly difficult time. But Guido believes the critical key to treatment may lie in uncovering what happens in the brain chemistry of anorexic patients when they starve themselves. He argues by stopping eating, they actually put themselves into a ketogenic state, which calms their brain and makes them less anxious. But this is a consequence of stopping them wanting to eat again. For all of us, if we don't get enough sugar, our bodies go into ketosis and then run on fats instead. And there's increasing recognition across a range of diseases that ketosis can have a huge impact on our brain chemistry. So Guido and his team wondered what would happen if they put anorexic patients into ketosis, not by starvation, by feeding them a ketogenic diet. An initial small study of 5 anorexic patients who had regained weight but still had major food anxieties and concern were put on a ketogenic diet. Normally, in patients like this, the relapse rate is around 50%. But in this case, all 4 patients who remained on the diet stayed healthy. And the researchers also saw a dramatic reduction in the patients' eating concerns and phobias. And Guido is now following this up in a new study. So could a ketogenic diet offer a potentially successful approach in managing a heartbreaking disease which has proved so intractable to treat? But before we get to Guido's interview, a brief request from me. If you enjoy this podcast and would like to leave a review on Spotify or Apple, that would be much appreciated. It really helps. You can also become a paid supporter of the podcast at patreon.com or via PayPal on my website. A huge amount of work goes into both the research and production of this podcast, so even a small amount of money makes a huge difference. And you can find out more information about the pod on my website, where you can sign up for the podcast mailing list, follow me on Twitter at Liz C. Tucker, and on my Substack account, liz.tucker.substack.com. Many thanks. And now back to Guido's interview. Dr. Guido Frank is a board-certified child and adolescent psychiatrist based at the University of California, San Diego. And his research interests are primarily focused on investigating brain biology that underlies eating disorders such as anorexia nervosa, bulimia nervosa, and binge eating disorder. He is especially interested in understanding what role biological circuits in the brain play. So Guido, thank you very much indeed for joining the podcast today. Here's Guido's interview.
Hi, it's wonderful to be here.
I suppose the reaction of many medical professionals when hearing about the possibility of using a ketogenic diet to help anorexic patients is a nervousness that any approach that suggests a particular way of eating or puts restrictions on what an anorexic patient can eat.
Yeah, and understandably so, since we know ketogenic diet in the context of people wanting to lose weight, and the idea of using a ketogenic diet to maybe help gain weight or not want to lose weight is a very new concept. Although I have to say, as you know, the ketogenic diet has been around for a long time to treat seizure disorders. And in that context, it really helped reset, normalize brain function, and has been very successful, in fact. So it is, I think, an important aspect of the ketogenic diet that we can change brain neuronal function. And I think we're just starting to explore how this can help in psychiatric disorders, including anorexia nervosa.
So anorexics are a group of patients who are not eating enough to maintain their body weight. Typically, what are the classic psychiatric and psychological traits you tend to see?
people essentially self-starve themselves because they feel this drive to do so. And it's driven by an intense fear of gaining weight or becoming fat. They're highly afraid of becoming fat, even while they're underweight. And then there are other aspects to it, such as what's called body image distortion or disturbance. They feel or perceive themselves as fat despite them being underweight. There's a subgroup where they see themselves as fat. Most people, they are aware that they're not, but after eating, especially, their fear of becoming fat takes over and it feels very, very uncomfortable. And paradoxically and interestingly, while people are emaciated to the point of their heart being really low, their bodily functions, maybe kidney function, liver function, are quite out of the normal range, they don't perceive themselves as ill. And it's very hard for them to recognize that there's an illness. Since you mentioned traits, I wanted to add that while not part of the diagnostic criteria, anorexia nervosa is typically associated with high anxiety. Those folks are very perfectionistic. They're very driven. They want to work very hard and do a very good job. But that also comes with a very high, what's called intolerance of uncertainty. It's very hard for folks to manage the unknown, and control and being in control is a very important aspect to feel more comfortable with life.
Anorexia, although it may start as a physical condition, over time this alters the brain's metabolism, and that has an impact on how the patient thinks and acts.
Yeah, so it is very hard to identify what exactly causes the disorder, right? In psychiatry, we have been struggling quite a bit with figuring out what are the genes, what are the predisposing biological factors. We know there are a lot of environmental factors also involved, but it's been really difficult. But the model that we have been developing and working with for our studies is there's usually a trigger. And the trigger can be many different things. So maybe somebody better in soccer and exercises a bit more and runs a little bit more and eats a little bit less. And that person, all of a sudden, 3 months later, has anorexia nervosa. So they never wanted to lose weight or had that in mind, but something has changed. Others, they may be wanting to lose weight. Others, they maybe have been afraid of choking or throwing up. So it's really, I think, goes across the whole eating disorder spectrum, that there's some sort of a trigger that makes people change their eating. And changing in eating typically involves food restriction, eating less, but then that also can go along with binge eating, eating large amounts of food in a short period of time, because people do get hungry, right? And some people, they binge eat and purge.
And that's more bulimia.
Yes, individuals with anorexia nervosa, they may also binge eat. They may also eat large amounts of food and throw them up in a short period of time, but they still eat so little that their body weight is very low. But once you are in a state of changing your eating, two very important things are happening. One is you develop an expectation and you learn that food and eating are somewhat negative. You condition negatively to eating, and when you see certain foods, especially high calorie ones, then you feel uncomfortable, right? Because you're afraid of gaining weight. And with the weight loss and changing your body weight, there is a whole host of changes in your body and your brain happening. There are, of course, all kinds of GI, gastrointestinal systems disturbed, but also there's a lot of change in the brain. We think there's especially a hypersensitization of dopamine circuits, and that then enhances the anxiety that people experience.
So to try to find out what was going on in someone with anorexia's brain, you carried out an experiment giving sugar to some people with and without an eating disorder. You looked at their brains in a scanner. Can you explain what you found?
Yes. What we use is a task that lets you understand brain function when people expect a high caloric stimulus, in this case, sugar solution, where we looked at how do brain regions really interact with each other? How do brain regions interact with each other when you taste the stimulus? And what always is striking is when you work with folks with anorexia nervosa, how people can override this drive to eat. most of us get hungry at some point, and even if somebody wants to cut down somewhat their eating, it's very hard. So there must be mechanisms to override that. And there are, in fact, mechanisms that when you are in a dangerous situation, then you are able to override your hunger drive. So let's say you're in the woods, you're hiking, then you sit down and have lunch, and all of a sudden a wolf is in front of you. Then most of us will get kind of nervous. Most of us will get scared and then will try to get to safety. Now, here's the important thing. You still are hungry, right? You just sat down to eat. So there must be a mechanism to override that. And there is a circuitry, actually different circuitries from the frontal cortex to deeper sitting brain structures. They're called the ventral striatum, which has a lot to do with dopamine function. And from there to a region called the hypothalamus, which really lets you know about whether you're hungry or whether you're not. These studies showed that when you're in a truly dangerous situation, then you can override these basic drives. So what we believe based on that is that sugar in our experiment was perceived as a threat. And maybe this stands for food being in general a negatively conditioned, fear-inducing stimulus, then hijacks the circuitry that was meant for the wolf, for real danger, right? To then override appetitive drive.
Because we know ourselves, I mean, if I'm going for a job interview and I'm nervous, I'm not going to feel very hungry before. That's the same kind of thing.
Yeah, that's an excellent example. So we think that this high fear of eating then hijacks exactly those mechanisms, and that helps you perpetuate this vicious cycle of food restriction.
So food is now seen as a threat, basically.
It has become a threat, exactly.
Now, I was interested to see that actually you saw a different response in people with bulimia who usually manage to keep their body weight up, but they are vomiting and binging, as opposed to the anorexics who are losing body weight. I wonder if you can explain the difference you found between the anorexic patients and the bulimic patients.
When we look at folks with eating disorders, then they share certain behaviors, thoughts and feelings, and they are different in certain brain activation and brain function. But the real difference is that the underweight in anorexia nervosa sensitizes these dopaminergic circuits. And this probably helps reinforce the food restriction and self-starvation, because the anxiety runs on these dopaminergic circuits and they sensitize during food restriction. And then the anxiety gets essentially a turbocharge. On the other hand, folks with binge eating associated behaviors, bulimia nervosa, binge eating disorder, those folks tend to be at the high normal to high compared to the average population weight. And high weight desensitizes these dopaminergic circuits. Now, the problem here is then that those folks also temporarily try to override these appetitive drives because they have the same fears. And we know that folks with bulimia nervosa, they don't eat all day long. But then because these dopaminergic circuits are desensitized, they're weakened, they are not able to control this food intake compared to the anorexia nervosa group, they then have to give in, if you wish, and then have a binge eating episode.
And Guido, can you explain why dopamine is so important?
So dopamine is an important neurochemical for many functions in your everyday life. So we most prominently know it from Parkinson's disease, where dopaminergic circuits, they die essentially, and then you have a problem with motor function, right? It is also very important for learning and cognitive flexibility. And I think that's very much what we see in typically anorexia nervosa. And it is very hard for folks to then get out of this pattern of behavior that is highly fear-driven. That's where we think is an angle to help with treatment, because if we can normalize these dopaminergic circuits, then we might help them with the cognitive flexibility.
So if anorexic patients have this sort of heightened dopamine sensitivity, one thing you've looked at is using a drug to reduce that sensitivity?
Yeah, so we have been for quite a few years now used a medication called aripiprazole. Its use was really based on these imaging studies with the idea that this medication that is a dopamine D2 receptor called partial agonist helps normalize these circuits. So it helps with cognitive flexibility. We also hope and believe that it can help desensitize those circuits. I always like to tell people the medication is not a miracle drug. It's supposed to help open the door. And then you can have an easier time to walk through it. And what patients often say is, yeah, I'm not quite as anxious around food. So suggesting that it does help. And the psychologists often ask me to prescribe it, but we still don't have any randomized control, typical medical studies on this medication because it's very hard to get funding for those. But from clinical experience, there's a lot of reason to believe that it is quite helpful in this process.
Because up to now, there's been no medication approved for anorexia.
That is correct. And every behavior is associated with underlying neurobiology. That then brought me to think more about what is really the underlying circuitry. We've been thinking about that for a long time. And the aripiprazole, while it's quite helpful, we feel it's a little bit like, secondary.
Sort of treating the symptoms rather than the cause.
Yeah, exactly. When I thought about it, I thought, okay, let's say diabetes, right? You have a problem with your pancreas, and then you give insulin to help with the sugar go in the cells. But really, what we would ideally do is fix the pancreas. So I don't need these insulin shots all the time. I feel a little bit like aripiprazole. And I really would like to get to the pancreas in our model, the underlying cause for a problem.
Which sort of brings us to your work looking at ketogenic diets. Now, we should say this is still very new, and it's in 5 anorexic patients who had regained enough weight to be in a normal range, but still had psychological and psychiatric concerns, because sometimes those mental problems can actually get worse as they regain their weight, because in a sense their worst fears have been realized. They've put on weight. So you've tried using ketogenic diet in this selected group. Can you explain what you did?
Yeah, so I really want to also mention Barbara Skolnick, who spearheaded that study. She really found me and asked me if I'm interested in working with her and developing a study around the ketogenic diet. She has a niece who had for a long time anorexia and nervosa. The family was struggling, finding new ways and better ways to help her out. And then Barbara, she thought, well, let's try the ketogenic diet. And then also added on medication. It's called ketamine. And she recovered dramatically and she is doing well. So I know her personally. Based on that, Barbara and some colleagues developed this 5-individual study. And then I came later analyzing the data and looking at what the outcome has been. So they underwent a ketogenic diet. And what happens during a ketogenic diet, you switch from using sugar in your brain as your primary source of energy, you switch to using ketones. There's a different mechanism that the brain can use to supply itself with energy. The studies in neurological disorders, seizure disorders, have shown that this creates sort of a reset of brain metabolism. And in that study, folks went through 8 weeks of this diet. Later on, the ketamine was added. And what happened is a dramatic reduction in things like eating concerns, things like that. So these core eating disorder behaviors. When I looked at those data, I was like, wow, this is incredible. And I've been working with folks with anorexia nervosa for 20 some years. And it doesn't happen like that.
This was obviously just a small early stage study, but there wasn't a control group.
Correct. I have to add, putting a control group versus a ketogenic diet, it's very hard to blind that. I'm not sure that we even can do that.
Sure.
People always know what they're on.
It's not like a drug trial.
Right, exactly. You cannot blind it, essentially. I'm not aware how to blind that. It would be extremely complicated.
All you could do would be a comparative study. You could treat someone with conventional treatment and compare that with a keto. I'm assuming that's the only thing you could do.
Exactly. So that was really dramatic and that was fascinating. And only one person after 4 months then went down with her weight somewhat. And that's a person who relapsed as far as we can tell, but she also was not on the diet anymore.
And what's the thought process in using ketamine?
Yeah, I think that was more of let's try everything we can. The reason I think why it also has been helpful in this context is that probably those folks also had depression that then was treated with the ketamine, and ketamine is an excellent treatment for major depressive disorder. So ketamine by itself, as far as I can tell in some small studies that we did ourselves here at UCSD, has not been mechanistically changing the eating disorder behaviors, as far as I can tell. But what I have done myself in the past is when people had recovered from anorexia nervosa weight-wise, then often a very strong depressive illness developed, and then they very often responded very favorably to the ketamine. And that is why in the study that we're conducting right now, we are using the ketogenic diet without any ketamine at this point. So we really need to disentangle those two interventions.
You're probably aware of the recent study which suggested the ketamine was no better than placebo in reducing depressive symptoms in surgical patients with major depressive disorder.
Ketamine has an FDA approval for major depression. All I can say is that the IV ketamine, according to certain dosing guidelines, can be life-changing.
I suppose I'm just pointing to a recent trial which suggested that wasn't the case.
Yeah.
And I suppose with FDA and with indeed any other drug regulator approvals, a drug can be approved on a statistical benefit, which isn't always the same as the clinical benefit.
True. I do not dispute that. I haven't seen that the ketamine was in itself helpful in the individuals that we treated. So I treated myself, some people with ketamine in the hospital, and the eating disorder wasn't really improved. So I want to separate that really from the other intervention. The interesting thing about the ketogenic diet, so why could it be that folks with anorexia nervosa are already underweight? They restrict more and more. People want to lose and more. So what is the addictive quality here? I searched the animal literature, and what I found was that, in fact, when you're stressed and anxious, that interferes with your normal glucose metabolism. It interferes with how the mitochondria, so these powerhouses, energy creators in our cells, how they can utilize sugar. Folks with anorexia nervosa, they are very high performers. They work very hard, but that also comes with high anxiety, perfectionism, intolerance of uncertainty. And what if the anxiety and the distress people usually feel interferes with this glucose metabolism? If you then get into a ketotic state where you replace glucose with these ketone bodies, you break down fats and you create these ketone bodies, you have an alternative energy source. And secondly, these ketone bodies, they then help the brain create GABA. GABA is a major neurotransmitter in the brain that helps you feel calmer. It's very important to help seizures to reduce, but it also helps anxiety to go down. Is this maybe a secondary mechanism why this state is so appealing? Why people feel so calm? Some animal and human research showed that it may help with neuronal stabilization, kind of helps these neurons be not as reactive. And when you think about people who fast during Lent or other times, they also often describe sort of a sense of peace and calm. Ketone body development then might, via GABA, help you feel calmer. And I think that could be sort of two important mechanisms why this ketotic state is so desirable.
So you can produce ketones in your body through a ketogenic diet, but if someone is anorexic and they starve themselves, that reduces the level of their glucose. And at some point, that means their body too is using ketones rather than glucose to function. So that will alter the brain chemicals being produced.
Yeah. So when you starve yourself, like in anorexia nervosa, first you use up all your sugar, and then you start breaking down your fats. And then you get into a ketotic state via that mechanism. And that somehow feels good, likely from the mechanisms that I just described. If we have people eat a ketogenic diet that provides these ketones, then you wouldn't need to self-starve yourself anymore, because you supply your brain with exactly the type of energy, the type of fuel to create more GABA and help you feel calmer.
Both processes, you're producing large amounts of gamma, which basically help calm down your brain.
That's what we're hoping for, yeah.
Now, you're running the trials at the moment on normal weight, anorexic patients. If this goes well, how far away are we from seeing if this works in people who are anorexic and underweight?
So this is a tricky question, because I do not want to promote using this intervention at this point in folks who are underweight.
Of course.
Here's the rationale to work for now with folks who are at the normal weight, but still struggle with these thoughts and feelings a lot, is because those folks already eat enough to keep their body within a healthy range. Then helping them go to the ketogenic diet, we felt would be an easier step. In folks who are severely underweight, they are still having to get into the process of eating enough. So at this point, I want to be cautious. I'm hoping that the trial we're currently conducting will show the benefits that we're hoping for. And then we can gradually come up with ways to integrate that into typical or regular underweight population to normalize the brain faster and change really how we treat anorexia nervosa.
Because the tragedy of the disease is not only do people die, but those who survive can take years and years to recover. So if you could get in earlier, if the ketogenic diet shows promise, that might potentially have huge implications.
Yeah, I agree. The earlier we treat this, the better our chances are. I think we have to rethink what is really the best way of treating anorexia nervosa. We have for decades now used certain approaches. We have made some progress in terms of behavior intervention, in terms of some medication, but I think we really need to think about in new ways and test new ways that are safe to help people recover faster and, importantly, do not relapse. It is not that difficult to normalize the weight for somebody in a high level of care hospital setting. But the real trouble is when people go back out in their regular lives, all these daily stressors come along that put so much pressure on everyone that then opens the door for the eating disorder to come back in. I had an outpatient clinic in the past, and each August, several of my patients relapse. So I thought, okay, what's happening now, right? And what's happening? School starts, right? And there's so much academic, but also social pressure. I just admitted a kid yesterday who developed the eating disorder relapse when there was a lot of school stress. So what I'm hoping is that when people change their eating pattern, even after high level of care, refeeding treatment, then maybe we can help them not relapse. And that would be a major advance, because within the first 6 to 12 months, about 50% or so of folks relapse. Aside from the cost that it creates to the healthcare system, what makes me sad is how many months and years of their life they lose.
Yeah.
There are folks that I know are in their 20s and they say, I didn't really have a childhood or adolescence because I went from one treatment center to the next. It's kind of heartbreaking, really. That's how it feels to me.
But interesting, actually, when I've met people in later life who turned out to have had anorexia as teenagers, and this is just in my very small group of people that I know, they do still have slightly unusual thought processes around food, I suppose is the best way I can term it.
Yeah, most people probably continue with this negative conditioning to food. And problem is, if you're an anxious person and you condition to something negatively, that makes you worried or anxious, is very, very hard to get that out of your mind, especially when you were young, especially when it had a really strong value at the time. I like to compare that with the Velcro. If you're an anxious person and something fear-inducing comes in, it attaches to this Velcro and it just doesn't go away. Actually, I focus on that a lot in sort of the psychotherapeutic work that I do with folks to talk about exactly what you're talking about. These deep-sitting fears and worries about food and weight and shape that are so hard to get past. It does sound like that in the small study that we published, this really was helped dramatically with changing these metabolic pathways. And to be fair, we're just at the beginning to really understand energy metabolism in relation to psychiatric problems and anorexia nervosa.
We know that the disease tends to disproportionately affect women. Have you got any theories in terms of brain metabolism as to what might help explain that?
Yeah, that is a really great question. What happens with puberty, which is considered sort of a critical risk period for developing eating disorder, you have a dramatic surge in sex hormones, right? Estrogen, progesterone. And what happens is these hormones, they stimulate dopaminergic circuits. What I believe happens in the brain is that the sex hormones, they may overstimulate these dopaminergic circuits and then also triggering more anxiety. And this anxiety then enhances the negative conditioning and facilitates food restriction through these circuits that I described in the beginning of our meeting today.
And when will your trial finish, and how many patients have you got on your current trial?
We have 2 folks enrolled right now who are starting the diet, and we have several people in the process of getting enrolled. So we're extremely excited. Ideally, we can complete this within a year.
I was really interested in an earlier paper you wrote, if indeed we have these metabolic factors associated with anorexia, that actually you found similarities in terms of these factors between obese and anorexic patients, which perhaps is the last thing anyone would expect.
Yeah, I think that's where the separation of different factors come in. And what the low and the high weight eating disorders have in common is the fear of gaining weight. We also showed that different eating disorders had all elevated amygdala response, anxiety-related response when they saw the picture that predicted the high caloric sugar taste coming into their mouth. But where the difference lies is how they then respond, because what you eat and how you eat changes your brain. It changes your brain in opposite directions, whether you restrict or whether you overeat. And that then creates a biology that's not easy to bring back to normal. But the similarity are these cognitive emotional factors. The difference are these deeper sitting, let's say, dopaminergic neurons, how they respond, because they probably change in different directions to high and low weight. One thing I wanted to mention, because it really highlights the importance of this conditioning, these fears. We recently published a study where we looked at long-term outcome of folks with anorexia nervosa. And we followed up the folks in our study, and we had about 30 individuals who then responded, and we got their weight history years after they participated. And my original thought was it's probably the dopamine and these dopaminergic circuits, they then predict weight gain and weight trajectory. Well, I was wrong. What we found was that it was the expectation. So essentially the conditioning to the fear-inducing stimulus that predicted BMI and BMI change years after they had completed the high level of care treatment.
So it's the fear of eating the sugar, not eating the sugar itself.
Yeah, you could say that. It is this fear that's so deep sitting and it's so hard to overcome.
We're seeing an increase in anorexia. How would you explain that?
Yeah, that's a really interesting question. There are 2 main aspects that I could think of. One is our food environment is probably not the healthiest. One could argue that how much we eat or how much processed food we eat has an impact on our brains, and eventually people more or less vulnerable to that. So I could imagine this is part of it. The other really important aspect is, and we saw that through the height of the pandemic, is how stress really interferes with people's lives and well-being. And when you think about the kids who are already stressed, there's so many pressures these days. And I think that supports this model that I described to you, that stress and anxiety probably interfere with normal mitochondrial glucose metabolism. It's a very biopsychosocial process. You have biological predisposing factors, you have environmental factors that contribute to the triggers. And there's a certain group of people who are vulnerable. Some people develop anorexia nervosa.
Many people have argued that anorexia is the toughest psychiatric illness of all to treat. Where would you place it?
I agree. The problem is you work with folks who, because of the illness, they want to do more of the same, much more anxious if they cannot pursue that behavior. That is what you're sort of up against. And I have to say, using these brain models is very useful, because what I really want is that my patients understand what's happening and that they make the choice to get out of this. It's not necessarily going back to your old life, because your old life was maybe very stressful and anxiety provoking. So you also have to think about, okay, what's next? How can I help you maybe deal with all these stresses and anxieties in a different way?
The frustration that it's such a difficult disease to treat and overcome.
Yeah, I totally agree. I mean, it is very difficult to understand why somebody would starve themselves to death, why somebody would throw up food. It goes so much against what nature usually teaches us. And it wouldn't be uncommon for parents to bring in their child and feel simply baffled. But I think this model that I described to you is very strong. And I think as soon as we can take things out of the black box, out of the unknown, into a transparent, mechanistic approach, then we can develop novel treatments. And you can also work with your patients on, okay, let's see how has this been getting better or not. Then it becomes a cooperative work in progress. And that's the thing where the beauty lies, to help improve people's lives.
Well, Guido, thanks so much for talking today. Really fascinating research, and look forward to hearing how the trial goes. Thank you.
Thank you so much for having me. A pleasure.
Goodbye.
Bye-bye.
Hope you enjoyed the latest episode of the podcast. And if you've enjoyed it, if you could share the pod and leave a review on Spotify and Apple, I'd much appreciate it. It really helps. The podcast will now be taking a break, and we'll be back on Tuesday, the 4th of November. In the meantime, many thanks for listening.